Welcome to the Gonorrhea Masterclass. Get ready to deep dive into one of the oldest and most persistent STIs in the book, Neisseria gonorrhea, aka the clap. It's bold, it's fast spreading, and it's fighting back against antibiotics. But you're about to become an expert in spotting it, stopping it, and staying a step ahead. Meet the microbe, Neisseria gonorrhea. So, who's this troublemaker? Neisseria gonorrhoeae is a gram-negative diplococcus. Think of two coffee beans stuck together. It loves mucous membranes, cervix, urethra, rectum, throat, and even the eyes. It spreads through vaginal, anal, and oral sex, from mom to baby during childbirth, even by touching infected secretions. And it's evolved to stick, literally. It uses pili to cling to cells like a mountaineer scaling a cliff. Then it invades and multiplies. The result? Inflammation, discharge, pain, and if untreated, serious complications. Clinical signs. Loud or silent gonorrhea is tricky. Sometimes it shouts, sometimes it whispers. In men, burning when urinating, white, yellow, or green discharge, testicular or scrotal pain, some may be asymptomatic. In women, increased vaginal discharge, painful urination, bleeding between periods, pelvic pain, most are asymptomatic, which makes screening key. Left untreated, pelvic inflammatory disease, infertility, ectopic pregnancy, perihepatitis, aka Fitzhugh-Curtis syndrome. In all genders, rectal infections, pain, itching, discharge, bleeding, or nothing at all. Pharyngeal infections, usually silent but may include sore throat. Eye infections, red, gooey, and fast-moving, especially in newborns. Neonatal gonorrhea. If untreated in the mother, babies can develop gonococcal conjunctivitis, severe eye infection, disseminated infection, rare but serious. Prevention? Treat mom before birth. Diagnosis: spotting the sneaky bug. Today's gold standard? Nucleic acid amplification test. It's sensitive, specific, can test multiple sites: urine, vaginal, rectal, pharyngeal, urethral. Gram stain is still useful for symptomatic men with urethral discharge. It's quick and effective. Culture, not dead yet, especially important for antimicrobial resistance surveillance. Who to screen? Let's focus on high-yield groups. All sexually active women under 25, women over 25 with risk factors, new multiple partners, no condom use, MSM, men who have sex with men, screen at all exposed sites at least yearly. People living with HIV, pregnant women, screen early and again if at risk. Sex partners of anyone diagnosed with gonorrhea. Treatment, simple but powerful. First-line treatment, 2021 guidelines, ceftriaxone 500 milligrams IM in a single dose, if weight 150 kilograms. If toil 150 kilograms, treatment, simple but powerful. First-line treatment, per latest guidelines, ceftriaxone 500 milligrams intramuscularly IM in a single dose. If the person weighs 150 kilograms or more, give 1 gram IM. But what if chlamydia hasn't been ruled out? Add doxycycline 100 milligrams orally twice a day for 7 days. If pregnant, azithromycin 1 gram orally, single dose. Site-specific treatment tips. Pharyngeal gonorrhea, treated with the same ceftriaxone 500 milligrams or 1 gram IM. It's a bit more stubborn here. No proven oral alternatives. If chlamydia is present, treat for both. Gonococcal conjunctivitis, ceftriaxone 1 gram IM, one-time dose. Add saline irrigation of the eyes to help flush out the infection. Disseminated gonococcal infection, DGI, can cause joint infections, skin lesions, even heart or brain issues. Ceftriaxone 1G IV or IM daily for 7 days, minimum. If meningitis, increase dose to 1 to 2 gram IV daily for 10 to 14 days. Endocarditis, 4 weeks of IV therapy minimum. Avoid tetracyclines and fluoroquinolones in pregnancy. Always consult ID infectious disease for severe allergy or complications. Gonorrhea fights back. Resistance? Gonorrhea is becoming a world-class escape artist. It's resistant to penicillin, tetracycline, ciprofloxacin, and now showing resistance to azithromycin. Cephalosporins are our last reliable line, and even they're being tested. Always suspect resistance if symptoms persist 3 to 5 days after proper treatment, the patient hasn't had sex since treatment, there's a positive test of cure. What to do? Retreat with ceftriaxone 500 milligrams IM. Add doxycycline if chlamydia hasn't been ruled out. Send off a gonorrhea culture with susceptibility testing, ASAP. Follow up. Don't skip it. Retest at 3 months post-treatment, even if the client says everything feels fine. Why? Reinfection is very common. Pharyngeal infections, do a test of cure 7 to 14 days after treatment. Other sites, TSC isn't routinely needed unless symptoms persist or treatment failure is suspected. Partner management. Anyone treated for gonorrhea should have all sexual partners from the past 60 days tested and treated. No partner in the last 60 days? Treat the most recent one. No sex for 7 days after treatment, and not until all partners are treated too. Expedited partner therapy, EPT, is allowed in some regions. This means providing medication or a prescription for a partner without them being seen. EPT can help reduce reinfection and stop transmission chains fast. STI counseling and prevention. Here's what to emphasize during a counseling session. Abstain from sex for 7 days after treatment until all partners are treated too. Use condoms consistently. Limit number of sexual partners. Get tested regularly, especially if they're high risk. Return for retesting in 3 months to catch reinfection. Encourage partner notification and treatment. Prevention boosters. What's on the horizon? Research is exploring new ways to outsmart gonorrhea. Doxycycline PEP, post-exposure prophylaxis, may prevent bacterial STIs when taken within 72 hours after sex. Men before C vaccine for meningococcal B shows promise in offering cross-protection due to similar surface proteins. Not yet officially approved for gonorrhea, but watch this space. Quick recap. Gonorrhea spreads easily and often silently. First-line treatment equals ceftriaxone 500 milligrams IM, or 1 gram if weight 150 kilograms. Add doxycycline unless chlamydia is ruled out. Always test and treat all recent partners. Follow up in 3 months. Watch for resistance. It's real and rising. Prevention includes condoms, regular screening, and honest conversations. You did it. You just mastered Neisseria gonorrhea, one of the toughest bugs in the STI game. You're now equipped to test, treat, educate, and protect. Remember, in the fight against gonorrhea, knowledge is your best protection, and sharing it saves lives.